Hello friends, so today we will have a discussion on the diagnosis and management guidelines for drug resistant tuberculosis. So this I've tried to make it in a animated fashion so that these guidelines don't bore you and we will understand the logical explanation behind each point in this guideline. So first let's brush up with the basics, which are the first line ATT drugs, which are HRZE, H for isoniazid, R for rifampicin, and Z for pyrazinamide, E for ethambutol, and this is the HRZE. So the definitions are most important. Only this definition they have asked so many times in BPG. First is, if there is resistance to only one of the four first line ATT, then it is monoresistant tuberculosis. If it is resistant to rifampicin alone, then it is RR, rifampicin resistant tuberculosis. Next, if the resistance is more than or equal to 2 out of the 4 first line agents, then we will see whether the resistance is involving both the topmost H and R. If it is yes, then we call it as multi-drug resistant tuberculosis, MDR-TB. Or if it is no, then we call it as poly-drug resistant tuberculosis. So the same MDR tuberculosis or rifampicin resistant tuberculosis, if it is associated with the resistance to fluoroquinolones also, then we call it as pre-XDR, extreme drug resistant, pre-extreme drug resistant tuberculosis. Next, if it is also associated with group A drugs used in MDR-TB, which we will be seeing sooner, the bedaquiline or linezolid, or if it is both to these drugs, then we call it as extreme drug resistant tuberculosis, XDR-TB. So this basic definitions you should be knowing. Yeah, now let's see why this resistance happens. 4 reasons they have given. One is the gene mutations within the bacilli, rendering it not acted upon by our ATT. Next is inadequate treatment, and next is the program failure, where it is difficult to diagnose, or if it is diagnosed late after the development of resistance. So it can be a part of a program's failure also in detecting and treating MDR-TB. And it can also be patient's clinical characteristics which are rendering it resistant to the ATT. So let's see the test, how they are detecting this resistance and how to follow up a patient on treatment with ATT. So first, detection of drug susceptibility, whether the drug is able to control the bacterium or not, and resistance. First is susceptibility, whether the drug is able to inhibit the growth of the bacterium or not. This can be done by a phenotypic test by observing the growth of the bacterium. This is called what? The BACTEC MGIT 960 is the automated liquid culture medium which is utilized in the test we'll be seeing. Next is the rapid molecular testing, which try to test the genes mutated in the development of MDR tuberculosis, XDR tuberculosis. Let's now see this interesting test, which is BACTEC MGIT 960. This test utilizes O2 quenched fluorochromes, meaning you can just see it like a bulbs attached with oxygen. As long as oxygen is attached with this bulb, there will be no fluorescence. The bulbs are switched off. Okay. When this oxygen is extracted from this fluorochromes, they will fluoresce, give some light. Okay. This is what is used in this test. First, what happens is, there we add the liquid culture medium for the TB bacterial growth. What is the culture medium used? Modified Middlebrook broth is added to this fluorochromes. So to this, on the top of it, we are going to add the sample. Can be the sputum sample or any extrapulmonary sample. So this we are going to add to this broth. Yes. So what will happen now? The mycobacterium is a aerophilic, meaning it utilizes oxygen for its growth. So it has its meal, which is oxygen. It extracts all the oxygen from this fluorochromes. Now this bulb starts to switch on, so they get fluorescence. Okay, so this degree of fluorescence they measure. Okay, this degree will correlate with the corresponds with the number of bacterium presence. Okay, yes, and also what all the points you should be remembering with respect to BACTEC MGIT. First is it is a preferred method for drug susceptibility testing. Okay, and next is test both pulmonary as well as extrapulmonary specimens for both first line as well as second line ATT. Okay, the interesting point is the time taken, which is just 8 to 10 days. When you compare it with the gold standard solid culture medium, which is the LJ medium, okay, it takes actually 3 weeks. It is used for monitoring the response to treatment, whether it is still susceptible or not, whether the drugs you are giving is still killing the mycobacterium or not. You can test it. And also it is used for long-term follow-up in drug-resistant patients. After treating the drug-resistant patients, they will be called after 6 months, every 6 months, just to ensure that still they are out of this resistant mycobacterium. Okay, and recently, most important thing, this susceptibility testing has been extended to the group A drugs like BEDAQUILLINE, linezolid, and group B drugs like clofazimine, pyrazinamide. Okay, all this and delamidate, all these have been developed. Okay, these drugs we will be discussing, don't worry. So now you should know this test has replaced all the conventional LJ medium, and it is under NTEP or NTP program. Okay, yes, this is BACTEC MGIT. Now let's see the second group of tests, which are the molecular tests, which helps to diagnose these naughty genes which are responsible for resistance. First is, what I want you to know here is, just know the genes, what actually they do in the bacterium, and how these are employed by the bacterium to cause resistance to our drugs. And in such conditions, what you should do, we are given in a tabular form. Okay, let's see. First is this RPO gene, which is the RNA polymerase B gene. This is the site of action for your first line rifampicin. This RPO gene is mutated in rifampicin resistance. Okay. Next is your CAT gene and INHA gene. CAT gene is catalase gene. This is responsible for your activation of isoniazid. Okay, H. So this will cause mutation to isoniazid. Isoniazid won't act if catalase is mutated because activation doesn't happen at all. Whereas INHA gene, which is a promoter for your mycolic acid synthesis, which is the cell wall synthesis for the bacterium. So this is inhibited by your isoniazid as well as ethionamide. So if this is mutated, this confers resistance to your ethionamide, whereas this you should know, if this is mutated, high dose isoniazid still works here. This is the role of giving high dose isoniazid if it is resistant to INHA alone and not to CAT gene. Okay. Next is your gyrase A, gyrase B. This you would have known, like gyrase are the topoisomerase enzyme which inhibit the DNA supercoiling. Okay, this is involved in a step in DNA replication in the bacterium. So if this is inhibited by your what is a famous drug which inhibits this, fluoroquinones. So this is the action for your fluoroquinones. This, if it is mutated, if it is low level of mutation, your higher generation fluoroquinone like moxifloxacin works. So only we tell like this moxifloxacin, which are respiratory fluoroquinones, should be reserved for treating MDR TB. So only you should not use this moxifloxacin in excess for treating normal respiratory infections. Okay. Next, if it is high level, then it's resistant for everything. Next is your RRS gene and EIS gene, which are the ribosomal proteins which are inhibited by your aminoglycosides. Okay. And you should know one important thing here. If this RRS gene is mutated, no aminoglycoside can work. It is amikacin, kanamycin or caprimycin, all are resistant. Whereas if your EIS is mutated, then it is resistant only to kanamycin. Okay, so this is the list of genes till now they have developed as our testing program to diagnose this resistance. Okay, yes. So now let's see all the tests, 4 tests in tabular format. This, if you know, that's it. Okay, first, the cartridge based nucleic acid amplification test, which is the famous CBNAT. What it does, the principle is nothing but polymerase chain reaction, real-time PCR. It does to amplify the mycobacterial DNA specific DNA complex to diagnose that it is tuberculosis. Test for diagnosis of tuberculosis. And then what more it can do, it can also diagnose rifampicin resistance alone. Okay, and what is the time taken, lab turnaround time? It takes 2 hours for the samples to be processed. Then it detects resistance of only rifampicin. Okay, and it is fully automated, and it needs temperature of less than 30 degree for optimal functioning. And since it is fully operated, not much of training is needed for any technicians. Okay, next is your TrueNAT. What is the importance of this TrueNAT? Same principle, real-time PCR is employed. It is a chip-based test, and it takes only 1 hour. And one more thing is here, it also detects only rifampicin resistance. Here they actually need micropipetting into small samples so that this can be processed. This needs some technician assistance, and training is needed, and can be done even in periphery setting. This you should know. Periphery settings you can easily do, chip-based test. Next is your expert MDB or XDR. This is the test which uses nested PCR, and it just takes 90 minutes, just 1.5 hours. Okay, but here this is also, we are telling it XDR. So this actually was endorsed by WHO, and in this test you can diagnose mycobacterial tuberculosis as well as resistance of all of the genes which we have discussed earlier. Okay, but still they have not but still discussion is going on to include this under our program. It is endorsed by WHO. Next, and it has a maximum sensitivity and specificity compared with your drug susceptibility test. Next, line probe assay. This is what is utilized under your NTP. So here also same thing, PCR followed by reverse hybridization technique. It takes 1 to 3 days. So here what happens, all genes whatever we have discussed, this they will be testing, and so this you should be knowing. LPA is most important, it comes under NTP. Next, this is the LPA genes and their clinical interpretation. This table I have simplified in our diagrammatic representation. Okay. Next is our lab turnaround time, where they are focused on under your liquid culture, which is the BACTEC MGIT, which just takes 8 to 10 days compared with the 3 weeks of solid LG medium. As well as next, what you should know is LPA, which takes 1 to 3 days, but it detects the resistance of all the genes which you have discussed. Okay, those genes, if you see properly, they will be covering the first line ATTs as well as some of the first line ATTs. Then they will also cover the fluoroquinolones and second line injectables. Okay, this it should be covering. Next, CBNAT you should know 2 hours, and TrueNAT just 1 hour. Okay, this you should be knowing. Yes, so how are the samples collected first? This you should know how they collect the sample. So first, 2 samples they usually will tell. One is the early morning sample, and next sample is the under your supervision, supervised spot sample. 2 to 5 ml they should be collected. Not much of blood contamination should be there. Okay, as it can be lead to erroneous results. And it can be refrigerated if it takes longer time for transport. And for extra pulmonary specimen, always collect in saline. Never use formalin. It will kill the mycobacterium. Next, so this is the specimen collection center. They are collecting it in 50 ml tubes and packed in triple layer. Okay, like how we do it for that COVID sample. Same procedure they will be following in here also. And one specimen what we are giving is processed by your CBNAT technique. Then if it is found to be positive, then what you should do, this should be registered in your NICSHI program. Okay, NICSHI app, digital app, they will be registering the patient's name, and also they will register that the patient is CBNAT positive, and they will send the sample to the CNDST laboratory, which is situated in the district. Okay, so they'll the second specimen is used for performing fluoroquinolone as well as second line LPA, and further DST as applicable. Okay, So now we have diagnosed MTB. Next we will be checking for the resistance. The second sample will be used for, like they will be sending it to LPA, further LPA to diagnose what and all resistance is there. Accordingly, we can start the treatment for the patient. This is the proper specimen flow as well as operational process which is happening. Next, so this is the operating procedure. How they are doing? They are collecting in a 50 ml conical tube. Then they are having a triple layer packing with the cotton pads covered. Then they are packing it in a polythene cover. Then they are putting it in a thermocol box, okay, with coolant gels for transportation. Okay, this you should be knowing. Next, extrapulmonary samples. What are extrapulmonary samples? Fluid samples like pleural fluid, pericardial fluid, ascitic fluid, BAL, CSF, and FNAC, tissue biopsy, and lymph nodes. All these are possible. So among these fluids, all extrapulmonary fluids, better first line itself we can go for CB-NAT in periphery labs or TrueNAT if TrueNAT if TB containment facilities are available. Okay, CSF and FNAC are precious samples. So this CB-NAT can be done in peripheral labs, or if you have the possibility that the patient's CSF sample is very low or FNAC sample is very low, then better send it to a DST laboratory which are located in like referral centers, tertiary centers. There you can send, so that after diagnosing TB, they can also process the same sample for your resistance also, like LPA also can be done in that same sample. Okay, this you should know. C and DST and NRL, National Laboratories. Tissue biopsy and lymph nodes are also precious samples. Better to send directly to C and DST laboratories or NRL. Okay, national centers. Okay, now coming on to our patient groups where we are going to test. First is all presumptive tuberculosis patients, where the patients having clinical features and presumed to be tuberculosis, where you need testing. Next is the key population. Key population means here we should be giving more importance to them because the patient might be immunosuppressed like PL-HIV, where they are more prone for tuberculosis, and children, and extrapulmonary TB, which is AFB smear is negative, and sputum is negative, but X-ray is suggestive of tuberculosis. So here we need further good processing. So better in these patients, first line itself, upfront itself, go for CB-NAT testing. Okay. Next is your all tuberculosis patient. Now they are telling all tuberculosis patient, better apart from doing sputum AFP, also do CB-NAT. Next is non-responders treatment, obviously, because CB-NAT should be done to detect resistance, and then we will be further processing for LPA studies to diagnose resistance. Okay, so these are the patient groups. Next, so how are we going to treat these? Yeah, so before going on to treatment, let me give a short idea of 3 groups have been used in MDR-TB treatment. First is group A, which includes leoflox, bedaquiline, linezolid. Next is group B, clofazimine, cycloserine and therizidone. Group C includes this list of drugs. So now let's see how to remember these drugs. Now I will tell you a mnemonic, not only to remember this group of drugs, as well as try remembering in the same order like how I tell. This will help you to remember all the 3 regimens used in MDR-TB. So this is the mnemonic. I hope you are familiar to this game, flash game, which we play in childhood. What is this? A group of persons to be transported to the other side of the river so that they are not killed by these demons. So a small mnemonic for this, like best friends, they are in a line and they are giving a close try to cross a dam. Remember this is as a dam. Okay, dams which is yet to be passed as it is a emergency. Okay, so what is this? Best friend E, group A, B, bedaquiline, F, friends phenoquinone, which is moxifloxacin, and linezolid, and they are giving a close try, clofazimine, and close SC, cycloserine, therizidone. Okay, why are they giving a close try? To cross a dam. Dams: D, delamanid, group C, A, M, amikacin, Z for pyrazinamide, then which is yet to be passed, which is yet ethionamide, okay, and pass paramino salicylic acid. Next, since it is a emergency or they will be killed by the demons, so emergency E ethambutol MER miro, okay, meropenems, okay. So this is the group of drugs. Remember that in the same order. You will understand why in a short time, okay. Yes, see, now let's see the three regimens. Everything has a logical explanation, so don't worry, just understand how we can frame this regimen. First, oral regimen. So among this best friends line, first is oral bedaquiline, fluoroquinolone, moxifloxacin can be given oral. Next is among closamine, clofazimine, one group in group B. And in group C, what drugs we can give? Delamanid. See, delamanid is not widespreadly available in all centers in India, and also it is a reserved drug. So we are keeping it to act in the, if some drugs don't work, then we use this drug. So this you should not use upfront. So this you shouldn't include. Next, it is a oral regimen. Amikacin is a injectable, so this can't be included. Pyrazinamide, yes, it is oral, it can be included. Ethionamide, yes, it can be included. Next, paramino-salicylic acid has lots of side effects, so better don't include in this oral regimen. Next, in emergency, meropenem is a injectable, you know. Ethambutol is oral. So what all you can include? Yes, pyrazinamide, ethionamide, ethambutol. You have framed it. Next, along with high dose isoniatic acid can be tried. This is the shorter oral bedaquiline regimen. Next, among shorter injectable regimen, here you should know we are going for injectable preparations. Okay, so same thing as your shorter oral, like best friends, bedaquiline, fluoroquinolones, moxifloxacin, and group B, clofazimine, and in group C, delamanid, it's a reserved drug, don't use it upfront, it is not included. Amikacin is injectable, included. Pyrazinamide can be used, ethionamide can be used, para-amino salicylic acid can be used, and ethambutol can be used. Say short oral regimen, nothing, just exclude the topmost and bottommost, which is D, delamanid, M, meropenem. Other everything can be included in shorter injectable regimen. Okay, yes. Next, longer oral regimen. See, this is why we discuss this regimen. This is why we discuss this order. See, here previously they were just giving some group of drugs for 18 to 20 months, like whether he is resistant or not, they're just bombarding with all those 18 to 20 months drugs. Now it is pure and purely logical. Only if he is susceptible, then we will be giving these drugs. So they have grouped it like group A, B and C. Group A is the most potent area. Next is group B, next is group C. So group A, so here longer oral regimen. That means the patient is going towards extreme drug resistance. So here what you should do, you should give all your forces in. Bedaquiline, fluoroquinolone, linezolid, put all your force in. Next, group B, try giving 2 of the 3, like clofazimine, cyclosamine. This is the perfect combination for this. And if you find group A may 1-2 drugs are resistant, or group B may 1-2 drugs are resistant, then what you can do? You can cover it up by adding some groups from group C. How to add the drug? What order should be added? This is the order. Delamanid, amikacin, DAMS, yet to pass emergency. D, delamanid, amikacin, pyrazinamide, ethionamide, paramino-salicylic acid, and E, ethambutol, meropenem. This is the order of adding these drugs. Now let's see the interesting protocol followed for MDR-TB. First is you are going to test this key population and all the population for CB-NAT. If it is positive for mycobacterial tuberculosis, you are going to test immediately. Next specimen should be sent to testing for rifampicin. Rifampicin is found to be resistant. Then what you should do? You should obviously send for reflex testing for other fluoroquinolones, secondly injectables. So you are going to send it to DSK labs and bedaquiline, clofazimine, okay, whatever LPA possible we are going to do. Next, result, if you are seeing, if you found no additional resistance has been found and H isoniatic acid is resistant with either INHA or CAT-G, but not both. If it is both, even high dose isoniatic acid is not possible, okay, but not both. And fluoroquinolone is not resistant. Fluoroquinolone can be given. So here only what drug set we can give? We can give our famous shorter oral bedaquiline containing MDR-TB regimen, which are nothing but bedaquiline, fluoroquinolone, because fluoroquinolone should be given. Next, clofazimine, and also in that oral regimen we can also give those group of drugs which are ethambutol, pyrazinamide, ethionamide. Okay, this can be given. If you don't have any LPA results or LPA facility is not available, then what you can do is you should check for the exclusion criteria where you should not give shorter oral regimen. We will be discussing it. If it is yes, then go for longer oral MDR or XDR-TB regimen. Okay, or if you are testing resistance, here H resistance is detected for both CAT-G and INHA. Both means even high dose isoniazid won't work. Next, fluoroquinolone resistance is detected. That means it is going towards pre-XDR. Then you should obviously give longer oral M or XDR-TB regimen, which we saw group A, try utilizing all the three if possible. If one is resistant in among group B, try using 2. And if some resistance is there, then try using drugs in group C in the order of DAMS, yet to pass, and emergency. Delamide and amikacin, Z-pyrazинamide, ethionamide, pass, paraminosalicylate acid, ethambutol, meropenem. Okay, that's it. So this you should be following up. Then replacement schedule is just done as in just follow the patient, do drug susceptibility testing. So here if you find some resistance, just exchange the group of drugs which works out. Okay, this is actually logical with respect to treatment of MDR-TB and XDR-TB. Next, if it is rifampicin resistance is not detected, TB is there. So here what you will do? Obviously you will check for other resistance like H resistance or fluoroquinolone resistance. You will be checking. If your patient is not resistant to any group, go for drug susceptible TB regimen, which is normally followed for drug susceptible TB. Okay. If you found any H resistance, then you should check for all the other resistance as we saw in DST. LPA you should be doing. So here what you can find is there is a regimen for only H mono or poly drug resistant TB can be there. There is a regimen for it that you can follow. And additionally you will be following with any resistance, then you can modify as per the resistance. Okay, so this regimen is nothing but okay, yes, that's it with the diagnosis and the protocol how to approach a patient of resistant tuberculosis. We'll be soon coming with a good video of the treatment, how to treat this patient, what are the regimens followed, what are the side effects, what special situations you should be looking upon. This will be coming with the next video. So I hope you like this video. If you like this kind of videos, kindly comment your opinions so that we can improvise with further videos to come. Thank you.